Assalamu alaikum students.
Walaikum salam.
Today we'll take up one more important topic, that is the placenta. We'll study about the placenta in this class. Okay, so this is the objective. Describe the mature placenta and mention its functions as well as anomalies. Okay, so here you can see here, this is a picture showing you the fetus and within the uterus, and here you can see the structure here. This is called as the placenta. So this is the placenta here, just beside the fetus within the uterine cavity. So now we'll study what exactly is the placenta and how it functions and what is its role in the development of the fetus. So as you know, the placenta is an organ that helps in the nutrition as well as the gaseous exchange. So it helps in the providing the nutrition to the fetus. As you can see here, this is the fetus developing, and this is the placenta, and this is the umbilical cord through which the all the nutritions which are necessary for the fetus to develop, as well as the oxygen uh, supply, all these are provided by this organ called as the placenta. So it is an organ that helps in the nutrition and gas exchange between the fetus and the mother. So it is the only connection between the mother and the fetus. So it has two surfaces, as you can see here. If you take out this placenta, this is how it looks like. Okay. So it has two surfaces. One is called as the fetal surface, which is toward the fetus. This is the fetus here. So here this surface is called as the fetal surface, which is facing toward the fetus. That will be smooth. It will be smooth, and it is covered by a thin membrane called as amniotic membrane. So this is the amnion. So this is the amnion. It has been removed this side so that you can appreciate the amnion on the other side. So on this side we have the amnion, and the other side it has been removed. So it is usually covered by the amnion. Okay, and provides attachment to the umbilical cord. As you can see here, this is the umbilical cord, which is usually at the almost at the center, attached here. Here you can see here, this is the same placenta seen within the uterus. So this is the umbilical cord, which is the connection between the fetus and the placenta. So here is the placenta, the umbilical cord attached to the placenta. So it has two surfaces. What you are seeing, this is the fetal surface, and the other surface is called as the maternal surface. If you see the maternal surface, so this is the maternal surface which is attached to the uterus. This is the uterus, wall of the uterus here. Okay, so if you see the maternal surface, this will not be smooth, just like here. It is smooth here, but here it is rough as well as irregular. If you can see here, it will be rough as well as irregular, and it shows something called as cotyledons. They are going to be present around 15 to 30 cotyledons. These small lobe-like structures, what you are seeing, these are called as cotyledons, and these are limited by fissures in between these cotyledons. The space growing, this is called as the fissures. These are the fissures, and these elevated structures are called as the cotyledons. Okay, here you can see here the same part from the side view. So you can see, appreciate, these are the cotyledons. So if you measure this placenta in a full term, means after 40 weeks of pregnancy, that is called as full term. So the diameter will be almost 15 to 25 centimeters. It varies from 15 to 25 centimeters. And the thickness is usually around 3 centimeters at the center thickness. If you measure this thickness, so this is called as thickness. This is the diameter. Diameter is almost around 15 to 25 centimeters. And if you see the thickness, this is the thickness around 3 centimeters, especially at the center, because at the periphery, if you see here, it tapers and it becomes thinner and smaller. Okay, so it tapers at the peripheries, and at the center it will be almost 3 centimeters. And the weight is usually around half a kilo, 500 grams. Okay, so this will be the usual weight, and the surface area is almost 14 square meters. 14 square meters, even though it looks very small, almost 15 to 25 centimeters is the diameter. But actually, if you see the surface, if you spread it out, it will be almost 14 square meters. This will be same as that of the size of the respiratory tract, as well as the gut in case of the adult human beings. So this placenta acts as the same structure, that is the respiratory organ, that is the lung, as well as the gastrointestinal tract. Okay, so it functions as a dual organ. So coming to the normal site of attachment of the placenta, it will be, as I said before, I have told you in the previous classes, that usually it will be near the fundus of the uterus, as well as in the posterior wall. Near the fundus is the top part above the opening of the fallopian tubes. So usually it will be near the fundus and in the posterior wall. But I had also told you, as the pregnancies, multiple pregnancies are there, the attachment of placenta will come down and it will have complications. We'll talk about that later. Coming to the functions of the placenta, one is it helps in the exchange of metabolic as well as the gaseous products, exchange of the nutritions as well as the gaseous products between the maternal and fetal blood. Even though the maternal and fetal blood, I will show you later, even they come very close to each other, but they never mix. They never mix. Okay, so they come very close to each other, but they never mix. But there will be exchange of gases as well as the metabolic nutritions. Okay, one is exchange of gases, like the oxygen is supplied almost 25 ml per minute. Okay, and the carbon dioxide is removed from the fetal blood. All the carbon dioxide which is produced, because the lungs are still not functioning in the fetus and it cannot respire. So all the oxygen is supplied by the blood, as well as even the carbon dioxide is removed from the fetal blood. The second is exchange of nutrition, because still the fetus cannot feed on its own. So all the nutritions are provided again through the blood, like the carbohydrate, lipids, as well as the polypeptides, amino acid, vitamins, and whatnot. Everything will be provided by the same placenta, as well as even the electrolytes necessary for the fetal development. The third is it will also helps in the transmission of maternal antibodies, ready-made antibodies, because the fetus still is not capable of producing the antibodies to fight any kind of minor infections. Okay, so all these antibodies are provided directly by the maternal blood. Okay, so like the IgG, immunoglobulins, and other things. Then it also helps in this is was the exchange of metabolic as well as the gaseous product. Now the second important function of the placenta is the production of the hormones. So this is also a site where important hormones are produced, which will help in the maintenance of pregnancy. One is the progesterone as well as the estrogen, mainly the estrol, one of the type of the estrogen that is produced here, as well as the relaxin, which helps in the maintenance of the pregnancy, as well as the placental lactogen, as well as the HCG. HCG is very important because this will help in the determination of the pregnancy. Okay, so all these hormones are produced by by the placenta itself. Then also helps in the removal of the waste products. We saw one of the waste products was the carbon dioxide that is removed. Along with that, even the waste products. Okay, so like the urea, usually it is function removed by the kidneys, but again this or the kidneys are not functioning in the fetus, so the urea as well as other waste product, the feces, so that is also removed by the placenta. So the placenta is not only functioning as a respiratory organ, as well as the gut gastrointestinal system, also as a kidney, as well as the even removing helps in the removal of the waste products. Then it also has a barrier which is called as the protective barrier. It is also called as the placental membrane, or it is also called as the barrier. Okay, so what is this barrier? So the barrier protects the fetus as the maternal and fetal blood does not mix. Okay, so because there is a barrier between the maternal blood and the fetal blood, and it doesn't mix. So there are some substances which cannot pass through the placenta. There are many substances which cannot pass through the placenta. So there acts as a barrier between the maternal blood and the fetal blood. So there is a barrier. So this is called as the placental barrier. So this, how it helps, it prevents antigenic reaction. We'll talk about that, uh, how the antigenic reaction will take place. Okay. So it acts as a barrier. So all these are the functions of the placenta. One is the exchange of metabolic substances as well as the gaseous exchange, then the production of the hormones, removal of the waste products, as well as the protective barrier. Now we'll see what is the protective barrier. What is the barrier here? So this is, as I said, it is called as the placental barrier, or it is also called as the placental membrane. So there are four layers within this barrier or the membrane. So these are called as placental membrane or placental barrier. If they ask you, you should be able to explain these four. Okay, placental barrier or placental membrane. Okay, so the first one is the endothelium of the fetal blood vessels and basement membrane. If you take a section of this placental barrier, so inside you can see here there are the fetal vessels. Okay, so fetal vessel has endothelium. So this is one of the endothelial cells. It is so thin that it covers the whole, it forms a thin membrane like thing. So it's called as the endothelium of the blood vessels and its basement membrane. So these are the fetal vessels, and it is lined by very thin cells called as the endothelial cells. Then we have the extra embryonic mesoderm. Extra embryonic mesoderm. Here is the connective tissue. Okay, where we have the fibroblasts and other things. Okay, then we have the cytotrophoblast. We have studied already cytotrophoblast and syncytotrophoblast. Okay, so cytotrophoblast as well as the its basement membrane. Then we have the syncytotrophoblast. We also studied the syncytotrophoblast. So this is the syncytotrophoblast. Okay, so these are the four layers. So outside will be the fetal, the maternal blood, and inside these blood vessels will be the fetal blood. So this barrier, these four layers will act as a barrier between the maternal blood which is flowing here and the fetal blood here. Okay, so these are called as the placental barrier or the placental membrane. So I will repeat once again. So the first layer is the endothelium of the fetal blood vessel. As I said, this is the fetal blood vessel. So the endothelium lining vessel cells and its basement membrane. Then the second is the extra embryonic mesoderm, which is nothing but the connective tissue. Okay. Then we have the cytotrophoblast cells here and its basement membrane. And outside we have the syncytotrophoblast. Okay, so these are the syncytoplasm. As you know, syncytoplasm, they are called as syncio because they are look like as though they are joined together and they look multinucleate and there is no clear division. So this is called as the syncytoplasm, and cyto because the cells look clearly. Okay, so these are the four layers which will be present. But later I will discuss how two of these layers, especially the second and the third layer, will disappear and these become a very thin layer. Okay, so with the fetal blood vessels here, with the fetal endothelium, and outside we have just the syncytoplasm. Cytotrophoblast has disappeared and the connective tissue also has disappeared and the cell blood vessels very come close here. Okay, so this will happen later in the later stages. We'll talk about that and its complications. Okay, so these are the four layers which form the placental barrier or membrane, and this is almost the size of 4 to 14 square meter surface area, and it is equal to the total absorptive area of the adult intestinal tract. As I said, it is almost the size of that of the intestinal tract as well as the respiratory tract. So that is the size of this surface area. So it acts as the gut of the intestinal tract. Okay. Now, which are the, I said this is the barrier. So barrier means it will prevent any substance from passing through it. Okay. But there are some substances that can cross the placental barrier. So which are those? This is important because whenever you give something to a pregnant lady, you should be very careful of giving anything because you should know that these can cross the placental barrier and they can affect the fetus, developing fetus. So what are the substances that can cross the placental barrier? One is the organisms, very minute organisms like the viruses, especially the poliomyelitis virus can cross the placental barrier, which can lead to poliomyelitis in children, polio. Then also the AIDS virus can also can pass through. Measles virus as well as the rubella virus. All these viruses can pass through the placental membrane, as well as even some of the bacteria. Usually it will be the viruses, and a very few bacteria can cross through the placental barrier. So especially if there is infection of the poliomyelitis, AIDS, measles, and rubella in case of the mother, you should be very careful, extra careful. Okay. So because these viruses can pass the placental barrier. The second is drugs. Especially it is recommended that whenever there is pregnancy, we don't recommend any drugs unless it is recommended. If unless it is recommended, we don't give any drugs. Okay. So one of the drug which they used to previously give, like the thalidomide. Okay, this is a drug which previously they used to give to prevent morning sickness, especially in case of the early pregnancy stages. There will be the early morning sickness. The pregnant lady will feel vomiting sensation. To prevent that, they used to start giving thalidomide. This is an antiemetic drug. Okay. Then its side effects was they would develop uh, children or newborns with short limbs, short upper limbs and the short lower limbs. Thalidomide. Okay, you might have seen or rarely nowadays, but you can see in pictures. So there will be limbs will be very short. Okay, so this was the side effect. Suddenly they banned this drug, and it was totally banned now. But nowadays again they have started using it, not in pregnant ladies, but in case of the some of the cancers, especially the skin cancers. But it is not recommended in the case of the pregnant ladies because it leads to shortness of limbs. So drugs can pass through the placental barrier. Okay, why I'm telling this? Because you should know what are the side effects. Okay, what can cross and what can lead to some of the damages in the fetus. Then chemicals like insecticide. If there is any spraying of insecticide, the pregnant lady is kept away from such kind of insecticides. But there is also some advantage of crossing of the barrier, like the maternal antibodies. Ready-made antibodies are crossed from the mother to the fetus. So this is the advantage, but these are the disadvantages. Okay, organisms, drugs, and chemicals. These are the disadvantage of having these crossing the placental barrier. But there are some advantages, like as I said, ready-made antibodies from the mother are directly passed into the child. Okay. Then also there is something called as rhesus factor. You might have heard whenever they say blood group. So they say O positive, O negative, A positive, A negative, AB positive, negative. What is the positive and negative? That is called as the rhesus factor. Rhesus factor. Especially if the mother is RH negative, rhesus factor O negative or AB negative, A negative, and the baby is RH positive. Okay, A positive, O positive, something like that. Mother is negative and the baby is positive. In such conditions, the mother produces anti-RH antibodies within her, which causes hemolysis of the fetal red blood cells. Hemolysis means breaking down of the fetal blood cells. So that leads to severe decrease in the volume of the blood, and it leads to danger effect, very dangerous effects within the child. This is especially seen in case of the usually the first baby is untouched, but the future babies with the second, third babies can suffer. Okay, so this is also a very important factor, especially. So that's why in case of pregnant ladies, we always check about the RH factor. RH factor, A positive, A negative, O positive, and O negative. This negative positive, that is the RH factor, because this can cross the barrier. This also can cross the barrier, and it can lead to lot of damage to the fetus itself. So these are some of the substances which can pass the placental barrier. If not, other substance cannot pass. So only substance which can pass means some of the most of the some of the viruses as well as some bacteria, some of the drugs, some chemicals as well as the rhesus factor. But there is
Doctor,
also advantage of having the maternal antibodies crossing it.
doctor, I have a question.
Yeah, sure. Yeah.
The RH factors, is it
Yeah.
100% that the first baby will be not affected, or there maybe will be babies can be affected the first baby?
Usually in the first pregnancy, it is rarely seen. Okay, maybe some cases, but because the for the antibodies to produce, okay, the blood has to cross. But I said before that the blood between the mother and the fetus does not cross each other. Okay, so when it crosses at the time of delivery, okay, when the first child is being delivered, at that time, because the placental there is break in the placental barrier, so some blood can enter the mother, and now she starts producing the antibodies. So then this the first child has already escaped. He has already delivered. Okay, now the second child and third child, they are usually affected. Okay.
Doctor, can you explain much more about RH factor?
I
I
will not
didn't quite understand.
uh, I said when the mother is Rh negative and the baby is Rh positive. Okay, so the antibodies are produced within the mother, especially during delivery of the first child. If the child is positive and the mother is Rh negative, the blood can pass between the mother and the fetus during the time of delivery because there is break in the barrier at that time. So there at that time, some of the few cells can enter from the child to the mother. Okay. Now, because the mother is Rh negative and the blood is Rh positive, so there is production of the antibodies against the Rh. So that is called as anti-Rh antibodies. Okay. Though so the first baby has already delivered, so usually it is not affected. But the future babies, if they are again the future babies are Rh positive and the mother is already in Rh negative, then it can affect the children, the fetuses which are developing the fetuses. If the baby is Rh negative and the mother is now Rh negative, no problem. Okay. If the mother is Rh negative but the baby is Rh positive, then it can affect the future children, future fetuses. Okay. And it
Doctor,
will, yeah.
if you finish, can you please explain maternal antibodies because I didn't get it too.
Okay, there are different antibodies which are within the mother. Okay, just like we all have antibodies, but these antibodies are crossed ready-madely, which are produced. It is not produced in the fetus because the fetus is still not capable of producing any antibodies. These are good antibodies which will fight against all our needs. Okay, any kind of infection and other thing like the IgG, immunoglobulins, and other antibodies. So these are passed from the mother to the child directly, okay, without any production within the fetus itself. So these are called as ready-made antibodies which are crossing from the mother to the fetus because the fetus still is not capable of producing the antibodies. So this helps the fetus to fight against any kind of bacteria, viruses if it is minor. Okay. And even after birth, immediately after birth, these antibodies which are crossing from the mother to the fetus, now after birth the fetus has some capability of fighting the any of the infections. Yeah. Sahar, yeah, tell me.
Okay, so my question is the rhesus factor an advantage or disadvantage for the child?
What do you think? What do you think?
I don't know, I'm confused.
uh,
Disadvantage.
it is what is the advantage of having the rhesus factor, because it is affecting the future children. It doesn't help the fetus itself. It doesn't help the fetus, but it can help its siblings, coming future siblings. But there is advantage in maternal antibodies because ready-made antibodies are received by the fetus. But the Rh negativity in mother and the Rh positive in the fetus, it is actually the disadvantage because it will affect the future pregnancies.
Okay,
Okay, so it
thank
is
you.
not the advantage. It cannot be advantage, right? Okay,
Okay, now
we'll move
it's clear.
further. Okay, now coming to the umbilical cord. So umbilical cord, as I said, is the connection between the fetus and the mother. Only connection between the fetus and the mother. So it is through the placenta. As we saw, this is the placenta. This is the side view, cut section, and here this is the whole thing is the placenta here, and above this is the umbilical cord. Okay. So now the umbilical cord is shown transparent so that you can appreciate the structures inside that. Okay. So if you see within the umbilical cord, it consists of two umbilical arteries. Arteries. If you see here, there are two umbilical arteries. Okay. Usually arteries are shown in red color, but here they are shown in blue. Do you know why? Why they are shown in blue here?
artery و vein blue.
Yeah. But here I said there are two umbilical arteries. These are the two umbilical arteries, but they are shown in blue color. Arteries usually we show in red, but here we are showing in blue color.
One bring the oxygen and the other one take off the CO2.
Yeah. So here the umbilical arteries are carrying the impure blood. They are carrying the carbon dioxide, CO2, back to the mother. That's why even though we call it as arteries, they are carrying the deoxygenated blood or the blood with carbon dioxide back to the mother. So these are umbilical arteries, even though they are shown in blue color. And if you see here, there is only one umbilical vein, but it is shown in red because it is carrying the oxygenated blood from the mother to the child. Okay, so colors are important here. Appreciate that there is only one umbilical vein which is bringing the oxygenated blood from the mother to the fetus, and there are two umbilical arteries which are carrying the deoxygenated blood, that is with which has the carbon dioxide back to the mother for the gaseous exchange. Okay, so there is one umbilical artery and two umbilical veins. Here in the bracket I have mentioned something. Okay, so these are the remnants in the future once the fetus come out of the mother. So these two umbilical arteries will become as ligaments. These will be called as the median umbilical ligament, and the umbilical vein will become the ligamentum teres. This is important later because when you study them, you will study these structures later in much more detail. So remember these two umbilical arteries after the birth, these umbilical arteries will become remnants. Remnants means they degenerated and they become ligaments. They are called as the median umbilical ligament, and the umbilical vein will become the ligamentum teres. Okay, so these are the two umbilical arteries which you can see here, as well as one umbilical vein. Along with that, to protect them, there is a thick jelly of fat. Okay, this is called as the Wharton's jelly. Wharton's is the scientist who found this. So it is called as Wharton's jelly, which is around these umbilical arteries and vein. Okay, to prevent damage, to prevent compression, or to prevent any kind of decrease in blood flow to the fetus. If there is decrease in blood flow, then it will affect again the child, the fetus, developing fetus. So to prevent that, there is a thick pad of fat around it. It has a special jelly called as the Wharton's jelly. Okay. Apart from that, there can be other two structures. One is called as the urachus and the Michel's diverticulum. This is not shown in this picture, but remember this. This is the distal part of the allantoic diverticulum, okay, which is called as the urachus, as well as the vitalo-intestinal duct, that is called as the Michel's diverticulum. Whenever I get to show, I will inshallah try to show these two structures. Right now here you cannot see them. Okay, so it can be seen in the developing fetus. Okay, so these are the five structures which are within this umbilical cord. One is the two umbilical arteries which are carrying the deoxygenated blood, and one umbilical vein which is carrying the oxygenated blood to the fetus. Then around that we have the Wharton's jelly, as well as sometimes you can also appreciate the presence of urachus as well as the Michel's diverticulum. These are the five structures which are there within the umbilical cord. Now coming to the anomalies of the placenta as well as the cord. So one of the prominent anomaly is the placenta previa. Placenta previa. What is this placenta previa? We'll talk about that. So as I said, within the uterine cavity, the fetus is present here and the placenta here. This is a normal position. Okay, I said usually it will be attached near the fundus and the posterior wall. Sometimes what happens, or with multiple pregnancies, it has been observed that the placenta keeps getting attached to a lower position. Okay, or sometimes if there is any abnormality within the uterus also, it can happen that the placenta, instead of being in the normal position, it is usually attached in the lower positions, like here. So this is called as the placenta previa. What happens if there is placenta previa? So especially during delivery, so it will be a difficult delivery, especially if it is centrally. There are different types. There are different types here. If you can see here, there are different types. One is called as the lateralis, where the placenta is quite far from the, this is the cervix here. So it, depending on the cervix, it has three types, or sometimes it is also shown in 4 degrees. Okay, the centralis, marginalis, and lateralis. If you see here, this is called a centralis, where the total cervix is covered. Here, this is the centralis. So it is totally covered by the placenta. Okay, the lateralis is quite away from the cervix. Okay, even though it affects sometimes, it doesn't much affect, even though it is away from. Sometimes it is marginalis, part of it margin is covering. So whenever the cervix dilates, at that time it will slide away. Okay, especially it will be covering initially, but during delivery it slide. So it might cause some problem, but still there can be there can be delivery. Even if there is some difficulty, it will deliver. But in case of centralis, it is totally covering whatever might be the size of the cervix dilatation, but it doesn't allow the fetus to come out at the 9th month. So you are supposed to do the cesarean sections, okay, C-section, and then you have to remove the fetus. So this is called as the placenta previa. So as I said, there are different types: centralis, marginalis, and lateralis. Centralis is this one, lateralis is this one, and marginalis can be this one. Initially it will be covering it, but with dilatation of the cervix it will slightly slide. Okay, so there are also some physicians also describe it as 1st degree, 2nd degree, 3rd degree, and 4th degree. Okay, so this is called as the placenta previa, where the placenta will be much more below than the what is normal, and it is usually covering the cervix. So cervix is important because it creates problem in delivery. Second kind of anomaly is called as the battledore placenta. Battledore placenta. The cord is inserted at the periphery of the placenta. As I said before, normally the placenta will be here, and the cord, that is the umbilical cord, will be at the central or slightly away from the central, but it is near the periphery. This is where it is called as the marginalis. So it is more. This is the normal one. This is the marginal one. And there are other types like the truncate, where it is dividing into multiple. As we saw, it is a single cord, but sometimes it will have multiple branches. Okay, sometimes it will be very diffuse. Okay, so this is called as the battledore placenta. Here, especially this part is called as the battledore placenta, where it is attached laterally. Then there are also accessory placentas. Addition, accessory means additional, which are useless or functionless. Okay, so one is the bidiscoidal. Sometimes the placenta is two. Usually I said there will be one placenta. Sometimes there can be two placentas. Here you can see there are two placentas. Okay, same placenta has been divided into two, or sometimes there can be actual two placentas. Sometimes it can be lobed. The placenta is not a single rounded, as we saw, it will be almost circular. But here, if you see, it is lobe, multiple lobe. Okay, so this is called as the lobe placenta. Sometimes it is diffuse, it doesn't have any shape. So it is very diffuse, some structure like. It is not circular as it should be. Okay, so that is called as diffuse. Sometimes the placenta is called as placenta succinata, okay, where a placenta is normal is present. Along with that, there is a small additional lobe. It is not bilobe. Here it is two complete, almost of the same size. But here one placenta is normal. It is big normal, but a small placenta, additional placenta can be seen away from the center. Okay, and sometimes you can see holes in that placenta. If you see here, there is a big hole. This is called as the fenestrated. Fenestration means putting holes. So you can see holes, big holes within the placenta. This is called as the fenestrated placenta. And sometimes a very dangerous type of placenta is present. This is called as the circumvallate, where the placenta, usually the placenta is developing on the decidia. Decidia is the endometrium of the female, the uterine endometrium, uh, where the endometrium is when there is pregnancy and there is implantation, then that endometrium is called as a decidia. Usually the placenta is attached to the decidua, but sometimes you can see here the decidua has been reflected out and it is totally adherent to the wall of the uterus. This becomes very dangerous because it cannot be separated from the at delivery. There is two types of two deliveries. One is the delivery of the fetus itself, then after some time there will be delivery of the placenta. But in this case, there will be no delivery of the placenta. It is totally attached and you cannot leave it because there will be severe bleeding. So in this kind of placentas, you are supposed to do the hysterectomy. Hysterectomy means removing out the whole uterus. Okay, just to prevent the bleeding, severe bleeding, and death of the pregnant lady. Okay, so at that time you are supposed to do the hysterectomy, where you remove the whole of the uterus itself. Okay, so these are some of the,
Doctor,
yeah,
what you mean that the woman that
yeah.
cannot be pregnant again?
Yeah, if there is circumvallate and if it is totally adherent to the myometrium, here instead of endometrium, this placenta will be attached to myometrium, the second layer. Okay, so at that time you cannot leave that placenta like that because that will lead to severe bleeding and the death of the pregnant lady. So you are supposed to remove the whole of the uterus itself. Okay, so when once you remove the uterus, then you cannot go for the future pregnancies. So there is a loss, but to prevent death of the lady itself, you have to do sometimes. Okay, there is no other go. Okay, so this we will study more when in the future levels. Okay. Okay, now coming to one more thing called as the surrogate mother. Today you studied about the in vitro fertilization, IVF. Okay, so usually IVF is done in those ladies who cannot get pregnant because of many reasons. Maybe it is from the male side or the female side. Okay, so usually they do the in vitro fertilization outside the body, and then they will implant back the fetus, the growing zygote, you can say, because it is in very early stages, zygote back into the mother. Okay, but sometimes the mother is not capable of actually sustaining that pregnancy because there might be the congenital anomalies within the uterus, which we have studied before. There can be double uterus, or sometimes there can be total atresia of the vagina or the cervix. In those cases, we go for an adopted mother. So outside marriage, somebody, some other female who can carry this pregnancy till birth. Okay, so such kind of mothers who carry somebody else baby just for helping or sometimes for the money sake. So such kind of ladies are called as surrogate mother. So in case of in vitro fertilization of the zygote of female with the husband's sperm, so that is called an in vitro fertilization. But embryo was transferred to uterine cavity of another female after pre-treatment, for after the treatment of that embryo or the zygote. So if it is transferred to some other female, okay, in case of any incapabilities within the mother, so at that time the pregnancy is carried by some other lady. So such kind of mothers are called as surrogate mothers. So these kind of pregnancies have their own problems, especially legal problems. Okay, so that we will study again in case of forensic medicine or some other, in some other places. Okay, so this is just the introduction, brief introduction to how all these things are important. Okay, now we'll go to some basic development of the placenta, how the placenta has developed. So we studied the placenta, then the umbilical cord and the anomalies. Now we'll go to some development of the placenta. We had studied some part of the basic development of the placenta in the initial stages. We'll today we'll try to cover up more about the same. Okay, so if you see the development of the placenta, we have seen two important structures. So the placenta will be developing from the trophoblast, which consists of two types of cells. While this trophoblast differentiates itself into cytotrophoblast and the syncytotrophoblast. Okay, so this will be differentiate trophoblast into two layers. Okay, cytotrophoblast and syncytotrophoblast. The syncytotrophoblast sends finger-like projections villi that will invade the endometrium, that is the decidua. Now it is called as decidua. These villi erode the decidual blood vessels, forming the lacuna in the intervillous spaces filled with maternal blood. I will show you all these pictures. Okay, so this takes place at around 12 cells of the syncytotrophoblast penetrate more deeply into the lacunae, become continuous with the maternal sinus blood. So maternal blood can enter the lacuna system, which is called as the uteroplacental circulation. I already discussed all these things. If you remember this, okay, this is the endometrium, and here this is the developing fetus is in the two-layer stage. We studied it in two-layer stage, then it becomes three-layer stage. Here it has become three-layer stages. And the trophoblastic cells which were around, these were the cytotrophoblast and the syncytotrophoblast. Now if you see this syncytotrophoblast, now they start giving rise to villi-like projections, and they start eroding into the endometrium, which is the decidua here. And if you see, endometrium is highly vascular, so you can see many blood vessels. Now within this syncytotrophoblast, there is production of spacer. These are called as lacunae. Okay, so as these syncytotrophoblast erode these blood vessels, now the blood vessel starts opening. If you see here, the blood vessels start pouring their blood into these spaces called as lacunae. Okay, so this is the maternal blood flowing into the lacunae. Okay, so with this flowing of the blood, even though the fetus is still far away, so this transmission of the food and the nutrition from here to the fetus, it is still far. Okay, so this is called as the uteroplacental circulation, with the flowing of blood into the lacunae. So this is called as the uteroplacental circulation. So the maternal blood will flow into the sinusoids, and the maternal blood enters the lacunar system, which is called as the uteroplacental circulation. By the appearance of the extra-embryonic mesoderm, here we had seen, so initially it will be just the trophoblast, and here you have the yolk sac, and here is the amniotic cavity, the amniotic cavity. So now in between, we had seen the development of an extra-embryonic mesoderm. If you remember, we had seen the development of extra-embryonic mesoderm. It has two layers. One is the splanchnopluric, and the other is the somatic layer. Somatic layer will be here, and this will be the splanchnopluric. Okay. By the appearance of the extra-embryonic mesoderm, the wall of the chorionic vesicle is called as the chorion, and we had seen these three layers which will form here. This will be called as the chorion. Today there was a question on the chorion. Okay, so the three layers, which are those layers? That is the somatic layer of the extra-embryonic mesoderm, then the cytotrophoblast and the syncytotrophoblast. Together they are called as the chorion. Chorion is being formed here, and here it is already formed. Okay, so this chorion, as I said, is a combination of syncytotrophoblast, cytotrophoblast, and the outer layer of the extra-embryonic mesoderm. Together it is called as the chorion, or it is also called as the chorionic plate. So here is the chorion being formed. Okay, now what happens? How it becomes placenta? Still it is in very early stages. As you can see here, it is still in very early stages with this villi-like projections and the uteroplacental circulation. Now there are changes within the trophoblast. Trophoblast are the same cells. Okay, By the beginning of the second month, trophoblast is characterized by a great number of second degree and third degree villi that give it a radial appearance. If you see here, so this same villi which were very irregular here, now by the second month they become much more regular and they become the second degree and third degree villi. We'll see what is the second degree and third degree villi. So these are villi like projections, okay, finger like projections called as villi, okay, which are going from the fetal side to the maternal side. Now there is something called as the chorionic plate, the extramedullary mesoderm lining the inside of the trophoblast that borders the placenta from the fetal side. So if you see here, this is called as the chorionic plate. This whole thing is called as the chorion, which consists of three layers, and this is the chorionic plate, which is nothing but the extramedullary mesoderm. Okay, chorionic plate, extramedullary mesoderm, lining the inside of the trophoblast cells. Trophoblast cells will be here. Okay, so it is lining from inside. So the cytotrophoblast, the border that placenta from the fetal side, that border the placenta from the fetal side. Fetus is here, so it is facing the this border, which is called as the chorionic plate. There is also another plate developing from outside. This is called as the decidual plate, because this is the decidua, endometrium of the mother. So the decidual plate, decidual basalis border the placenta from the maternal side. From the maternal side, that is the mother side, there is one more barrier being formed. This is called as the decidual plate. So there are two plates here. One is the chorionic plate and the decidual plate, and in between you can see these are the chorionic villi. The outer cytotrophoblast shells attach the villi to the maternal side. So if you see here, they are going from the fetal side to the maternal side. So they are attached to both the plates, chorionic plate and the decidual plate. So they are attached, okay, from here to here. Lacunae or intervillous spaces between the villi, and in between, if you see here, these are called as the lacunae. Intervillous space, because these are the villi, and intervillous means in between the villi, which are called as lacunae. Now, if you see here, the blood vessels are opening into these lacunae. Okay. Now, something called as the chorionic fundosum. Chorionic fundosum. So what is this chorionic fundosum? It is bushy or chorion, the villus chorion, well-developed villi on the embryonic pole. Initially, if you see here, if you see the uterine, if you imagine this, the uterine cavity, if you take a section at this level, in the early stages, inside is the fetus. It is not shown here, but if you see here, chorion are developing on all the sides. Okay, so what chorion you saw here? So this chorion, these are the villi. So all they are developing on all the sides initially. In the initial stages, they all are produced everywhere. But in the later stages, you see here, the chorionic villi are developing only on one side. In the other side, they disappear. They totally disappear. So this part where the villi are developing, this is called as the chorionic fundosum. Bushy or villus chorion, well-developed villi on the embryonic pole, where the embryo is there. So that part will have large quantity of villi, which will form the later of the placenta. Okay, so these are called as the chorionic fundosum. If you see here, the same villi later develop into placenta. So here the chorionic fundosum, which will form the placenta later. Then there are something called as the chorionic leaf. Chorion means finger-like projection. These are the chorion. So where they develop, they are called as chorionic fundosum. Where they leave, where they disappear, so they are leaving. So that is called as chorionic leaf. Smooth chorion, villi of the embryonic pole. So where they disappear, this part is called as the chorionic leaf. So chorionic fundosum and the chorionic leaf. Then similarly, just like the chorion are of different types, even the decidua, that is the endometrium of the uterus. So this is the endometrium of the uterus. This is the myometrium, muscle, thick muscle. So here is the endometrium. Okay, so the endometrium or the decidua is also divided into three types. The decidua basalis, decidua over the fundosum, the part of the deciduous near the chorionic fundosum. This part of deciduous is called as the deciduous basalis. Once again, I repeat, deciduous is nothing but the endometrium. Okay, so where the fetus is attached and where the chorionic fundosum are growing, so at that part, this part of the deciduous is called as the deciduous basalis. Okay, then the part where they are the chorionic fundosum disappear, so a thin layer of the deciduous still covering it. So if you see here, the deciduous, the brownish layer still covering it, so light brownish. Okay, so that part is called as the decidua capsularis. Decidua capsularis. Okay, and the decidua in the remaining part of the uterus, that is called as the decidua parietalis. Parietalis. It is also called as the decidua vera, but right now you can remember these three. So there are two chorions: chorionic fundosum, finger-like projections, and the chorionic leaf where they disappear. This part. So chorionic fundosum and chorionic leaf. Chorionic leaf will be present here, which are disappearing. They are leaving. Then talking about the decidua basalis, where the chorionic fundosum is there. Then a part of the decidua covering the whole of the fetus. This is called as the, it forms a capsule. So this is called as the decidua capsularis, and the remaining part of the endometrium in the uterine cavity, that is called as the decidua parietalis. Decidua parietalis. If you see in the later stages, as the fetus develops, become larger and larger, all these cavities disappear. If you see here, now the fetus is covered by completely by the amniotic cavity, and the yolk sac has become very small. We'll talk about this later in the next class. Then there is a cavity here called as this chorionic cavity that also disappears. If you see here, it will disappear. Then the uterine cavity where there is separation between the deciduum capsularis, this one, and the deciduum parietalis, they all fuse here. You see here with the developing of the fetus, so all these cavities disappear and all the deciduum get connected to each other. But here, this part where we have the deciduum of the chorionic fundosum and the deciduum basalis, that will grow into placenta. So deciduum basalis and the chorionic fundosum, that will develop into the placenta. So something called as the amniochorionic membrane. So the same thing is called as the amniochorionic membrane. Fusion of the amnion and the chorion that obliterates the chorionic cavity. As I said, so there is the obliteration of the, with the development of the fetus, the amniotic cavity and the chorionic cavity fuse together. So this membrane now it is called as the amniochorionic membrane, because the amnion and the chorion has fused together. It is thin membrane that ruptures during pregnancy or during delivery, especially during labor. Okay, so this is the membrane here. So the amnion and the chorion has fused together, and is called as the bag of membranes. Okay, it will rupture before the delivery. Okay, so these are the membranes. Okay, we usually call it as just membranes. Okay, it is nothing but the amniochorionic membrane. Now coming to the villi, we have seen these are the finger-like projections, which are called as the villi. We also saw here, also we saw these are the villi. Now we are talking about these villi. Okay, so how they develop it. So villi, they are essential functional elements of the placenta. So these are the most important structures. These are the well-developed villi. So these are the functional elements. These are the structures which are actually helping in the exchange of gases, nutrition, everything. So these villi are very important. Okay, so these are the villi. So connect the chorionic plate with the basal plate, as we have seen the decidual, the chorionic plate with the decidual plate. Consists of three types of villi. Now we should know that three types: first degree, second degree, and third degree, or the primary, secondary, and tertiary. These are the pictures. This is the primary villus, secondary villi, and the tertiary villi. So how they differentiate? So development of the villi. At around the third week, the trophoblast is characterized by primary villi that consists of the cytotrophoblast core covered by a syncytotrophoblast. If you go back to this picture, if you remember, this is the picture showing. Okay, So in the early stages, there is only the sincere trophoblast. Then the cytotrophoblast entered. So this sincere trophoblast with the cytotrophoblast, this is called as the primary villi. Primary villi. Okay. Now the extraembryonic mesoderm also starts entering. Now this becomes the secondary villi. You see here. Now if you can appreciate, you can see here. So initially there will be only two layers. If you take a section of this villi in the early stages, it is just the cytotrophoblast inside and the syncytotrophoblast. Then we can see the entry of the extraembryonic mesoderm. So extraembryonic mesoderm has entered. So now there are three layers. The primary villi, there are only two layers. Now there are three villi. In the tertiary villi, now the blood vessels start growing in the fetus from the fetal side. So these are the fetal vessels. Okay, so this starts growing. Now, if you take a section at this level, this is how it looks like. So this is the maternal blood. Maternal blood has flowed into these cavities, which are called as intervillous space or the lacunae. Okay, and the fetal blood is flowing through this vessel. So there is a barrier between this maternal blood and the fetal blood. This is called as the placental barrier. Okay, so this is how it looks like. This is the syncytotrophoblast, cytotrophoblast are present in some places and other. And here you can see the blood vessel and the connective tissue. So this is the three types of villi: primary villi, secondary villi, and the tertiary villi. If you go back to this picture again, so this is the primary villi with the syncytotrophoblast and the cytotrophoblast growing. Then the extraembryonic mesoderm comes. Then it is called, if you take a section at this level, then it is the three layers: cytotrophoblast, syncytotrophoblast, cytotrophoblast, syncytotrophoblast, and the mesoderm inside. Then there will be blood vessels growing into these vessels. Okay, then it is called as the, so this is the same villi which are growing. Okay. Okay. Now coming to some of the types of villi. Just a minute, hold on. Okay, now if you see here, so these are the three types of villi. Now we are seeing the same villi here. This is the well-developed villi. So this is the picture of the villi. So here is the fetus. Now it is floating within the amniotic cavity. This is the umbilical cord, and this is the whole placenta. This is the whole placenta. We are taking a small section of this to show the villi. So this is one villi. So there are types of villi. Some are called as anchoring villi, and some are called as free villi. Anchoring villi fix the cooling vesicle to the decidia. So they are fixed from one side to the other side. So from the maternal side to the fetal side, they are totally connected. Okay. So these are called as the anchoring villi. And some of these branches will be floating, and these are called as the free villi, free villi. And within this is the intervillar space where there will be blood. If you see here the same thing, so this is the anchoring in the center, and the branches are called as the, the free villi. Some are floating within the intervillar space. So this is especially for the exchange of the materials between the maternal and fetal blood. So the maternal blood is here, fetal blood will be here. Okay, so fetal blood will be here, and this is the red colored. This is the maternal blood. Okay, now coming to the divisions of the villi. Within the villi, there are different parts. Okay, what are those? There are three divisions. One is called as the truncus coriae. Yeah.
Sorry, doctor, can we continue tomorrow because it was a heavy day?
Hmm. Tomorrow. Okay.
Yes, we have two classes, I
Yes,
think.
doctor, please.
Okay. So okay, we'll stop here. Inshallah, tomorrow we'll continue. Okay.
Thank you, doctor.
Okay.